Now, the GI portion of the lecture, and then I wanted to mention some things about the trach care real quick for the respiratory conclusion. I know we did our respiratory, but there was just some key components I thought you would want to know about trach care. You will have a trach, and then, do this again. You will have this business, this trach and this vent business. I don't think I got a picture, so I need to do that. You'll have this as part of cardio or respiratory, because if you have a cabbage patient, you know you're going to be on vent, so vents and trachs and all that good stuff. But I did discuss some portion of the trachs with your laryngectomy. But so I want to just get this picture real quick. Forgive me, guys. Okay. Now, so let me say some things I can erase off the board fairly quickly. I wrote down all the vent information the other day, but I just want to make sure you got the holy hookup. The trach care, you know I taught you Saturday, you better have an obturator a size smaller, because this thing can come out. It doesn't matter if it comes out a year later. It's within 7 days that it's a medical emergency. So it's called decanulation, and it is a medical emergency. So you will call a code for this. 4 of you from my NCLEX course don't do homework. Gotcha. I know, you should, but whatever you don't have, don't do. About that. Okay? Yep. I won't, but you can. Decanulation, as I was saying. The trach came out within 7 days. The patient is a code blue. You are going to make sure you hurry up and get the positive pressure and boo bag. Do you guys know what that is? I don't want to assume. It's where you really have a big old bag and you're squeezing. But what do? You have to do the stoma. You can't do the mouth. You have to do the stoma. Okay, so you're going to go crazy with the ambu bag. You're screaming. Your room is filling up with 900 staff members, all your friends, and they're panicking too. So we're all panicking together, and the room is very busy, but you can't do it by yourself. So code blue, remember that. Now, there's just 2 big deals. Remember, when we talk cuff talk, we're talking fenestrated trachs, aren't we? Big deal. Huge. Fenestrated trachs with a cuff allow you to talk, they allow you to cough, and they allow you to, we don't even do late. What is the problem? No, I don't even want to hear that.
They're babies.
Huh?
They're babies.
They are babies. Y'all is grown. Y'all teenagers. But they're little babies. Okay, so y'all missing the best part. Damn. Okay, so anyway, y'all catch up with these people. Seriously, the shit I'm saying is big. Okay? So this fenestrated cuff patient, trach, whatever. Why? Why is it that way? Because we want the patient to be able to talk. We want the patient to be able to cough. We want the patient to be able to breathe. Cough, breathe, talk. Now, how do you get them to do any of that? You have to deflate the cuff for talking. Deflate the cuff for talking. I said that Saturday, I'm saying it again. I wonder why. Deflate it before you suction. Deflate before suction on this patient. This patient, right, with the fenestrated cuff. So these are all huge, okay? Now, just some other tips. The patients that have an inner cannula, you know that we remove that. You use the little, what the hell are they called? Pipe cleaners, whatever. Remember, that's half strength peroxide, half strength normal saline. Half strength peroxide, half strength normal saline. The patient, of course, you're using normal saline. You don't do peroxide on the patient. Those are old ways we did things. You never, ever instill saline into the trach for suctioning through you. Because we found out through research that was bad. Evidence-based practice taught us that was actually really bad. So you don't do that. Remember that the cuff pressure has to be just perfect per the order, because you can cause excoriation of the tissue. You can really damage the tissue, okay? So we want you sharp on that. And then, yes, the strings. When we change the strings, you actually need help. Now that's something that I do with help. If you didn't have help just because life sucks, you know, as a hospital nurse or a long-term care facility nurse, I have used family. I know it sounds crazy, but I have used family. But I just like to hold on to those strings and don't remove those strings till you put the new ones in. Probably the best advice I can give you is do not take those strings out till you have those new ones in. Man, is it ugly when that thing gets out, okay? So, you know, you're gonna be fine. Now, ventilators really quick, so you guys got this. You can erase it. Oh, God, yes, that's on your procedures packet. Matter of fact, I love you, baby. Take that out. So you started stuff already. Then you got here this morning and you started some shit. Pull your procedures pack out. But listen to me. This has all of those instructions. It has keep 2 at the bedside with bag mask rescue. 1 slightly smaller, do you see that? In case of decanulation. Humidify. Postural drainage. Never irrigate. Suction only after. I mean, I really gave you the hookup on this. Okay? Just go and get the new one. You're okay, baby. She's like, shit, y'all got everything, I ain't got nothing. Goggles, she's like, shoot, I want that. Yeah, you got it, baby. We're gonna get you a new one. Goggles, how about you highlight goggles? Okay? Now, if it comes out, if you see the big bold print at the very bottom of that little list, if it comes out 3 months from now, you can put it back in. But if it comes out the first 7 days, I wrote this. Cold blue and ambu. We use a little rhyme. Cold blue and ambu. That's an ambu bag. Trach suctioning. Where is it sterile? Sterile in the hospital, not at the house. Never cut the gauze. I mean, everything you need is there, right? Okay. Never suction more than, look what I wrote, 10 seconds. No more than 3 passes. Thank you, honey. Give that one to her. And then that baby. That one wasn't here. You weren't here Saturday. Yeah. You're going to be kind of lost. She don't get one. She wasn't here Saturday. Yeah. But it's okay, baby. We're going to hook you up at the end, so don't worry. But anyway. Okay, so important little seconds. Between each breath, allow how many? 15 seconds. Suction off when you go down. Suction off when you go down. Did y'all learn that in lab? Mm-hmm. Okay, good. I do it like this, right? We say, think of it as a frosty cup, a frosty in a cup. You got to the end of your cup. There's a little bit around the sides. You just kind of, okay. Oxygenate before and in between. I have stupid abbreviations, so really watch what I'm saying. Before and in between suctioning. 3 breaths with an ambu bag. That's what hyperoxygenate means. And then also I would write this. Oxygenate, hyperoxygenate right after. I don't see it on here, so. Hyperoxygenate right after. Okay, so you should be okay on that. All right, so we're done with trachs, we agree? Okay, go to vents. Look at the vents on that procedures packet. You won't have much, but you will have machine alarms. Machine alarms are going to be on the page that is after the TTE, and it has diarrhea on the top. You should have something that says diarrhea. Keep going after TTE, yeah, and then diarrhea at the top. Keep going, baby girl. Y'all see the diarrhea on the top? Go down to the bottom. You have your machine alarms. Now, did you? What did you get? What was it? High pressure and low pressure. What to do with the high pressure? Oh, yeah. Okay. Well, you ain't gonna never forget it now. Okay, so now, machine alarms. You have your high pressure, you have your low pressure. Don't matter which one, does it? You check the patient first, technically, right? But why are they ringing in such a way? Well, the high pressure, you have a patient issue, no doubt. Sometimes it's they're biting the ET tube. Sometimes they're not paralyzed enough, right? They're not sedated enough. And sometimes they are completely congested and need suctioning. You can't tell which one. So you are going to auscultate the lungs and suction. That's your first nursing action. Auscultate the lungs and suction. Now, when we look at the vents, when we're checking all these vents, the FiO2, I wrote this before, is less than 50 on vent patients. That's why they need a vent. We talked a little bit about that. I'm just reviewing really quickly that respiratory distress was evidenced by a PaO2 less than 60, or a pulse ox, which is your SaO2, SpO2, less than 90. And what did we say the difference was between SaO2 and SpO2? Yep. Blood draw with a little bitty a, ABGs, and this is indirect pulse ox. But they both are the same values. What was normal again? 95 to 100. What's the normal PaO2? 80 to 100. So this is the bomb.com for you guys. Okay. Now, so the patient is either in respiratory distress when they end up getting this vent, which means we're in a hurry to get it in. Or we just did CPR, which means we really ain't keep things very sterile at all. Because if you've been in a cold, it should be flying all around the room. Okay? So spinal cord injury, probably a major emergency that shit's flying all around the room. And then traumatic brain injury. I don't know how many of you remember Congresswoman Cassie or Gifford. Yeah, I don't want to call it Kathy Gifford, was it? That's the actress. But anyway, y'all know who I'm talking about, the Congresswoman. Okay, here's the deal. She was shot in the head. So we want to put her in a coma because we know if you're shot in your head or you have a traumatic brain injury, if we have to get the oxygen to your brain, we can't afford to have none with you moving around. Because the more you move around, the more you use oxygen. We put you in a coma purposely when you have that type of brain injury. So if you work in neuro, you earned every bit of your money and they didn't pay you enough. They didn't pay you enough. Neuro is a bitch. Okay? So traumatic brain injury is going to be put in a coma purposely. So they don't use the oxygen up from the brain that needs it. Remember the whole shunting thing. Okay? Now, these patients are emergency patients. So here's our problem. We probably weren't using aseptic technique the best way we could. Would you agree? So they're at risk for ventilator-acquired pneumonia. You gotta know that. Ventilator-acquired. Uh-oh, the police in the house, baby. You the po-po? Oh no, you gotta watch her. Don't do nothing illegal in here, y'all. That's cute. I like that so funny. Oh yeah, that's what they all say. She's an undercover cop. Y'all watch it. Okay. Ventilator-acquired pneumonia is going to be because we did not use the most sterile conditions on most of these patients. And when we're talking about ventilator-acquired pneumonia, the most important thing you can do is mouth care. You might want to quote me. How would you know? The patient would have a painful cough. We do cultures, we do sputum culture. That will also tell us. But they'll have a painful cough. When it comes to ventilator-acquired pneumonia, this is almost half the people in ICU. So it's pretty serious stuff. It's not going to be something that, oh, I wonder if I'll ever see that. No, you're going to see it. It is the #1 nosocomial infection. The head of the bed must be up 30 to 45 degrees. Brush the teeth when you do the mouth care. Remember to brush the teeth. Xerostoma increases the risk. What is that? Dry mouth. Now don't forget to answer to every single question that asks about how to prevent an infection. It's hand washing. Hand washing green leafy vegetables, right, y'all? Every answer. Yeah, okay. All right, now Staphylococcus aureus, or MRSA, is usually the culprit. So MRSA is hard to treat. So we really have to do that mouth care. We have to keep the head of the bed up 30, 45 degrees at least. That's what you do for that prevention. Okay, now real quick, these ventilators. I had you copy this down. Sometimes when you look at it later, it's not going to make no sense. So when we look at this one, please spell these letters out on your notes. CMV is continuous mandatory ventilation. Continuous mandatory ventilation. Sometimes we just say assist control. Continuous mandatory ventilation, and sometimes we just say assist control. It is every single breath the patient takes is going to be assisted. The ventilator does all the work. It's the highest ventilator pressure, so it's the highest risk of hyperventilation. So you guys are going to remember, when patients are on high settings like this one, you can get them into a respiratory alkalosis. Because what is hyperventilation? Respiratory alkalosis. Okay? All K is low in alkalosis. All K low with alkalosis. Okay? Now, SIMV, synchronized intermittent mandatory ventilation. The words tell you what it is. It's intermittent. Short-term use. We believe this patient will not be with us that long. We know that they're doing really good. Or we're trying to get you to the point where you get off our unit, and we're trying to wean you. This weaning is a focus. Weaning is a focus. It's not much risk of hyperventilation here. And the patient can do their own little breathing, whatever they want to do, but when they don't, we do. Now, here's why I would use SIMV, and you're going to use SIMV all day long. It's so popular. It's because it preserves your patient's respiratory muscles. The pressures preserves the patient's respiratory muscles because they're still using them. Always remember, if you don't use a muscle, you lose it. And with the highest vent pressures in this one, you're not using your muscles. And they can atrophy. They can really be, screw you lady, I'm not going to breathe when you need me to breathe. So this one is preserving your patient's respiratory muscles. It means that, hey, you don't lose it, if you don't use it, you lose it. I'm using my muscles. Every now and then I'll crank out a breath. And that's helping me stay functional. Okay? All right. Peep. Peep is positive and expiratory pressure. You little love bugs want to focus on these two words. The end of expiration. So positive and expiratory pressure. This is where your patient is going to get some pressure, i.e. O2 in this case, at the end of expiration. As the ARDS patient improves, this would be what we'd like to see them on. So PEEP is the ventilator setting of choice for ARDS. Now, if the ARDS patient is really, really bad, near death, in other words, well, then they're going to go up here, aren't they, guys? If they're near death and they can't do any breathing at all. But because these are your spinal cord injury, ARDS, CPR. This would be a cervical injury above 4, neuro, little hookup. C4 injury and higher, then gotta say that again. C4, injury and higher, ventilator. Okay, now, CPAP and BiPAP, what's the most important thing you need to know? It's continuous. So it's not just at the end, it's continuous. It's not just at the end, it's continuous. Positive airway pressure. Both of these settings prevent atelectasis. Both of them. They do it differently. The CPAP BiPAP machine is for, and I didn't want to write it because it was too much, it's for exacerbations of pneumonia, exacerbations of COPD, exacerbations of any respiratory condition, but especially COPD. Sleep apnea is treated with this in the home. You're going to have a CPAP machine at the home. They've gotten so much better, they're not as loud and bulky because it didn't quite match Victoria's Secrets. Our patients were hiding them under the bed, throwing them in the closets, all kind of stuff. You got to remember your old folks are skating just like y'all are. They're getting their freak on. I just want to share that with you. So they don't use those machines because when their man come around, no, he don't need to know I need oxygen because then he'd be like, girl, Okay, so yeah, they threw the CPAP machine up under the bed. One lady told me, honey, it's in the closet under the furs. What? The hell? Okay, some bullshit. Okay, so air, not oxygen, is being delivered continuously. This is a quote. Air. Yep, because remember this was oxygen. Peep was oxygen. This is not oxygen. This is only air. It was a quote. It's delivered continuously, as we said. The difference between CPAP and BiPAP is that CPAP is going to only really give you the same exact pressures all the way through. BiPAP is going to give you higher pressures on inspiration than expiration. Look how I wrote it. Inspiration greater than expiration for the bilevel pressures. It's mimicking how we breathe. We use a lot more pressure to take in air. We use as much pressure to pull it out. Okay? Push it out, so there. Okay, y'all all right? Keep it moving.